Welcome to Psydactic. I am Dr. O'Leary, a fourth-year psychiatry resident in the National Capital Region. I make this podcast primarily for physicians, especially psychiatry residents and grown-up psychiatrists, but I hope anyone listening can benefit. I need to inform you that when I make this podcast, I speak only for myself. Nothing I say here should be mistaken for anyone else's opinions, especially those of Eli Lilly or AstraZeneca. Today, I'm going to discuss a medication that patients who saw psychiatrists between about 1997 and 2015 were very likely to find themselves prescribed. They may have even been prescribed it by their primary care physician. However, more recently, it has been taken down a notch or two on the prescribers' lists of preferred meds. This medication is Quetiapine, marketed as Seroquel by AstraZeneca in the United States. Whether you were diagnosed with schizophrenia, bipolar disorder, depression, anxiety, an eating disorder, insomnia, PTSD, borderline personality disorder, obsessive compulsive disorder, and many others, it appeared in the mid-2000s that Quetiapine was just the right thing for you. By 2010, Seroquel was raking in about $6.8 billion annually in sales. That same year, AstraZeneca was fined about $500 million for clandestinely promoting off-label uses of Quetiapine while covering up data about its side effects. The Quetiapine global market in 2023 was only about $160 million. This, in part, has to do with it coming off of patent, so it's cheaper, and there are other drugs that are competing with it. And I don't have to have a degree in math, but if Quetiapine has only been prescribed for what it had been thoroughly researched to treat, and maybe there's some spillover with off-label prescribing, I imagine it probably would not have reached more than about, I don't know, maybe $500 million annually. Some data I perused showed it was prescribed more for depressive disorders than for psychotic disorders. And if you add depressive anxiety and sleep disorders and compare them to psychotic disorders were dwarfed in comparison with the number of prescriptions. Now, there are two $500 million and a billion, and 2 times 6.8 billion is 13.6. So that means that in 1 year alone, 2010, AstraZeneca made at least 12 times what it may have made, and then paid only about one of those 12 times in fines. That's only in 1 year. The math is telling me that it is at least an order of magnitude more profitable to get caught encouraging poor prescribing practices than to do the right thing. There was also some sex scandal where pharmaceutical reps might have been trading sexual favors for industry secrets, but now that I have your attention, I'm going to disappoint you by saying that I'm not actually going to talk about the sex scandal. AstraZeneca also got benefit from a decade of exaggerated or hidden information, and that made an indelible mark on the institution of psychiatry and even family medicine doctors. While prescriptions of Quetiapine have waned recently, at least in part, like due to the newer agents coming out on the market, they may be substantially higher still than they would have been without that decade of market manipulation. I have met a prescriber who uses Quetiapine even in lieu of well-established and evidence-based practices because, well, he insists that it works on everything. And it might work on everything as he proposes, but I have seen very little evidence that it actually does a good job of most of that. And Seroquel comes with far more side effects than are normal for first-line and second-line therapies. The reason that quetiapine has been used for so many indications is that it has a really broad receptor profile. It hits all kinds of receptors, including like histamine, acetylcholine, norepinephrine, serotonin, and dopamine receptors. Quetiapine was developed in 1985 by AstraZeneca in an effort to create a compound that was at least as effective as clozapine for psychotic disorders, but didn't have that pesky side effect of agranulocytosis and infections that would kill people. In fact, clozapine had been taken off the market in 1975 and wasn't even put back on the market until 1990 after establishing strict tracking and monitoring criteria. Quetiapine and its sister medication, olanzapine, which was patented by Eli Lilly in 1991, both were developed to fill the gap that clozapine had left open. But neither proved as effective for psychosis as clozapine. But both were effective for psychosis, and they were both approved by the FDA. Eli Lilly beat AstraZeneca to the punch by securing an FDA approval for olanzapine for schizophrenia in 1996. Quetiapine was not approved until 1997. Now, there's somewhat of a myth that, like, first-generation antipsychotics are strong D2 blockers, and second-generation antipsychotics are strong 5-HT2A blockers that also block D2 receptors, so that makes them better. I mean, this vast oversimplification really gives us, I think, a really highly misleading concept about the various antipsychotics, and you can see some of my episodes from December of 2023 if you want a more in-depth discussion of that. Now, I'm not sure if second generations are that much better than first generations, but it would surely benefit pharmaceutical companies to promote a myth like this. Those new drugs we develop are better and have fewer side effects, so use them instead. In my literature searches, I found very little evidence of this. And I don't think that psychiatry itself or psychiatrists in general have insisted on better neuroscience of their antipsychotics. And primarily because, well, we're not neuroscientists, but secondarily, I think we know more than we actually do about them, and some of that was very misleading. This is dangerous. We are, however, getting better. Despite pharmaceutical company cover-ups, disinformation, and this culture of credulous gullibility, we have now over 2 decades of experience with quetiapine and some longitudinal evidence to draw from. Quetiapine is currently approved for schizophrenia. It is also FDA approved for acute manic episodes, and it is among 5 antipsychotics that are approved for the adjunctive treatment of major depressive disorder. There's evidence that it can also treat bipolar depression. It is also often given, among many other things, for the maintenance in bipolar type 2 and in anxiety disorders. It's also given in post-traumatic stress disorder, various kinds of insomnia, disorders in that obsessive and compulsive chapter of the DSM, various personality disorders, especially borderline personality disorder, and that's a very short list. I haven't seen studies that give any strong evidence for any of these off-label indications, and I haven't seen studies that show that it is, on average, better than anything else that we prescribe for these indications. Of course, that doesn't mean it's ineffective. The fact that I haven't found those studies doesn't mean that it's not effective. I'm just having a hard time confirming that. Its broad range of uses are likely related to how messy of a medication it is. I mean, it coats dozens of receptors on neurons at various affinities. So, and to complicate things, really, one of its metabolites, norquetiapine, has its own receptor profile distinct from quetiapine. So you could even say that quetiapine itself is just a prodrug, and norquetiapine is doing a lot of the work for it. So after taking quetiapine, receptors all over the place end up blocked. And At higher levels of the drug, you also get substantial blockade of the norepinephrine reuptake transporter, but I'll get back to that in a minute. Psychiatrists will know what I'm talking about when I mention Stahl's illustrated guides. I mean, these guides do a great job of helping physicians understand like the proposed mechanisms of psychotropic medications, including antipsychotics. But I think their illustrations are somewhat misleading. To demonstrate the receptor profiles, they show like this crude circular cell with various receptors sticking out. That, for example, like quetiapine hits. So in quetiapine, the two largest receptors on that cell are 5-HT2A and D2. And they may have drawn them very large because, well, these receptors are thought to be the most important for its approved indications. But if you were to list the receptors for which quetiapine itself has the highest affinity, not norquetiapine, but quetiapine, in order, the top five would be the histamine 1 receptor, the alpha 1A receptor, the alpha 1B receptor. These are things that norepinephrine would hit. And the 5-HT2A receptor, a serotonin receptor. And then the dopamine type 2 receptor. For norquetiapine, the top five are that histamine receptor, the 5-HT2B, the muscarinic 5, and muscarinic 3, and muscarinic 1 receptors. These are receptors that acetylcholine hits. Norquetiapine has a moderately higher affinity for the D2 receptor than quetiapine. But to get there, it needs also to first fill the 5-HT1A receptor, the 5-HT2A receptor, that norepinephrine transporter, the 5-HT7 receptor, the alpha 1B receptor, the 5-HT1E receptor, the 5-HT2 receptor, the muscarinic 4, M4 receptor, and that alpha 1A receptor. Now, I could not find a good estimate of the relative plasma levels of quetiapine versus norquetiapine at stable dosing. Well, one paper reported that only 1 to 2% of quetiapine is excreted unchanged, which suggests a lower concentration of quetiapine than its metabolites. But another paper reported that the concentration of the metabolites were about 12% compared to quetiapine, and these seem to be in conflict. I don't think that we really know the answer. One paper noted that the mean norepinephrine transporter occupancy in the thalamus was 19 and 35% respectively, and that's after doses of 150 versus 300 milligrams of quetiapine. I found that the dose of venlafaxine necessary for a 35% occupancy rate of the norepinephrine transporter is about 150 milligrams. So it might be that a dose of 300 milligrams of quetiapine would end up having a clinically significant activity at that norepinephrine transporter, at least similar to venlafaxine, which means that it could be anxiolytic and also potentially promote cognition and attention. Another potential anxiolytic action of norquetiapine is that it's a partial agonist at 5-HT1A, and it has a higher affinity for 5-HT1A than it has for that norepinephrine transporter. But let's not forget what else norquetiapine and quetiapine hit. Long before they have significant blocking action at the norepinephrine transporters, or they're partially agonizing 5-HT1A, they're blocking the histamine 1 receptor, that alpha 1A receptor, and the alpha 1B receptor, which could be sedating or drop someone's blood pressure. I feel like the action at the norepinephrine transporter might be counteracting that hypotensive effect, but this likely takes some time. So when you're first starting quetiapine, it's best not to just give doses above like 50 milligrams, especially immediate release, because it might put someone on the floor with some sort of syncopal event, after which they won't want to take it again. But once they get used to it, and norquetiapine's really at a more stable level, and it's hitting that net transporter, then that might be less likely to cause hypotension. But I'm not certain about that. However, what patients continue to feel with quetiapine, and generally as long as they take it, are the sedating effects. This is the most commonly reported side effect, and it really doesn't appear to just completely go away with time, although it might get better. And this makes sense about quetiapine because the highest affinity it has is for the histamine 1 receptor, which is very sedating. This sedating effect is what made people excited, actually, to give quetiapine for insomnia, but this has proved to be a risky strategy. So doses up to 300 milligrams have been studied for insomnia, and quetiapine will sedate you. It does potentially help with sleep, but the problem is that there are numerous side effects, and I'm going to cover those in a few minutes. But first, I want to talk about its use as an antipsychotic, which it was approved for, and as an adjunct for depressive disorders. The 5-HT2A blocking activity of quetiapine is potentially antipsychotic. And it's also augmented to a great extent by norquetiapine, which also blocks 5-HT2A. And norquetiapine's affinity for 5-HT2A is about twice that of quetiapine. The 5-HT2A blocking properties of quetiapine probably contribute to its antipsychotic effects. But alone, this is generally not sufficient. For example, like drugs like pimavanserin, which are 5-HT2A specific blockers, do a really poor job of treating psychotic symptoms in patients with chronic psychotic disorders. You really need to block D2 receptors. For norquetiapine, D2 is the 15th receptor in the order of its known affinity, so it's hitting like 14 other receptors before it starts to fill up the D2 receptor. And for quetiapine, D2 is only the 5th. However, norquetiapine still has a higher affinity than quetiapine for this receptor. One of the reasons that drugs like quetiapine have lower rates of extrapyramidal symptoms is because its affinity for D2 is about 20 to 50 times less than more of the strong D2 blocking antipsychotics. So I've heard this called like a kiss and run because it doesn't really hug tightly to the D2 receptors, but it still reduces its overall activity. I'm not quite sure why quetiapine is effective as an adjunct in major depressive disorder, but to be fair, that's really a low bar to meet. There are a lot of medications that are given as adjuncts in major depressive disorder when our primary treatments don't work. But between quetiapine and norquetiapine, they are partial agonists at 5-HT1A and antagonists at 5-HT1D, 1E, 2A, 2B, and 2C. There are so many drugs with various mechanisms of actions that are used as adjuncts of MDD that I'm kind of reminded of something a surgeon once said to me. He said, if there are a lot of different treatments for the same thing, it means that none of them really work that well. Some of the worrisome side effects of antipsychotic drugs and quetiapine are their metabolic effects, such as weight gain, insulin resistance, increased fasting glucose levels, high cholesterol, and also generally reduced levels of activity. So this metabolic syndrome might be due to the muscarinic, histaminic, and 5-HT2C blocking properties. Now, I'm not going to do a really deep dive here, but the M3 receptor, the muscarinic 3 receptor, in various regions of the brain control food intake and insulin secretion. M3 is also present in pancreatic beta cells that secrete insulin. Over time, blocking these receptors in the brain might dysregulate appetite and also dysregulate blood glucose metabolism. The histamine 1 favoring antihistamines also increase appetite, and they also cause weight gain. And quetiapine's highest affinity is for the H1 receptor. Now, blocking 5-HT2C, which norquetiapine has a very high affinity for, also increases appetite, and it increases food intake. The weight gain caused by quetiapine was something that AstraZeneca was accused of covering up. Now, olanzapine, quetiapine's cousin from Eli Lilly, is notorious for weight gain. So maybe if people were to think that quetiapine didn't cause weight gain, it could tip the prescriber toward AstraZeneca's quetiapine. Now, here I'm just speculating, but we know that there are a lot of incentives for companies to do things. The additional side effect profile for quetiapine, like any psychotropic, can be very, very long. So if you think about the antihistamine and anticholinergic actions, you could expect things like having a dry mouth, dry skin, blurry vision, or like if it's in a toxidrome, things like urinary retention, hyperthermia, tachycardia, mydriasis, delirium. These are things you may have learned as a medical student, like mad as a hatter, high as a kite, dry as a bone, red as a beet, full as a flask, hot as a desert. The, the full as a flask part is not just the bladder. You might also be severely constipated or even develop an ileus, which is basically when your bowel just kind of gives up trying to move food forward. And this could be deadly if your bowel perforates. Ileus is a very common side effect of clozapine. Although clozapine gets most of its attention for agranulocytosis, ileus will kill you as well. And ileus is possible in quetiapine. But regular old constipation is really far more common. Now, agranulocytosis is also possible with quetiapine's use, but its incidence is so low and that it doesn't really require monitoring. Quetiapine, in addition to sedating people, which is why it's given at night, might also result in brain fog. But some people report improvement in cognitive function. So I think it depends on kind of where you start from. For example, if you are psychotic or maybe even severely depressed, then cognitive function will likely improve substantially if you take quetiapine. It was hoped that quetiapine might be beneficial for the negative symptoms of psychosis, and while it's less likely to worsen them than maybe some other antipsychotics, it's not likely to help much. There are some special places where quetiapine may be the best choice among other not very good options. For example, psychosis in those alpha-synucleinopathies like Parkinson's or Lewy body dementia might benefit from quetiapine or from clozapine or from pimavanserin, but other antipsychotics should be avoided because they're far more likely to worsen the dyskinesias in the alpha-synucleinopathies. Say that word like 10 times fast. Now, I've seen low-dose quetiapine being used for delirium as a second-line agent only after all of the environmental and behavioral interventions have been implemented first. And it's had some good effect. But as a psychiatric practitioner young in my career, it's difficult for me to distinguish between the mythology of quetiapine that was weaved together in the early 2000s and has continued to this day, and its actual efficacy. There's just too much noise in the signal. I think quetiapine is a good choice, especially for some patients with schizophrenia or with bipolar type 1 disorder, maybe even bipolar type 2. The risk versus benefit analysis kind of leans more toward taking quetiapine in severe disorders than it does in things like insomnia or anxiety. In these other disorders, I really feel like the jury is still out, especially because in the race to the top, quetiapine really hasn't been shown to be more effective than any other drugs for any of its indications. Thank you for listening. I am Dr. O'Leary, and this has been an episode of Psydactic.